Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bonjour, bienvenue. Hello and welcome to the June edition of Family Medicine Grand Rounds. My name is Doug Archibald, and I'm the Director of Research for the Department of Family Medicine, and I'll be today's session moderator. This is our final Family Medicine Grand Rounds of the academic year. We'll be taking a short break over the summer and then joining again in September. And already we've been building quite a good session for the upcoming academic year. So lots of great presentations, including today, following coming September, and spread the word. Let's try and make this a really rich, full session. So it's my pleasure today to introduce our speakers from the Winchester Hospital. They're going to be speaking to us today about some of the work that they have been doing. First of all, Dr. Sean Higgins, who is a PGY2 family medicine resident at Winchester, and his practice interests include comprehensive family medicine and point of care ultrasound. And upon completion of his residency, he'll begin practice with the Canadian Armed Forces. Dr. Adam Jones-Delcorde is a lecturer with our department in the Department of Family Medicine, family physician working at the Winchester District Memorial Hospital, and he's completed his residency at the University of British Columbia, followed by an extra year in emergency medicine at Queen's. He's worked as a family doctor, hospitalist, and emergency room physician for several years in British Columbia before returning to Ontario, where he completed his point of care ultrasound fellowship here at the University of Ottawa. His interests include medical education, rural medicine, and point of care ultrasound. So, gentlemen, I will now turn everything over to you.
Great. Okay. Good morning, everybody. Thanks for tuning in this morning. It's nice to see some familiar names online here. So we've been busy at our rural site here in Winchester, establishing a point of care training program in our rural family medicine residency here. So we're excited to tell you a little bit about it this morning. So I'll just spend a few quick minutes on some background, which I think is just important to frame the rest of our discussion today. You'll see different definitions of point of care ultrasound out there. And one I like is describes it as the acquisition, interpretation, and clinical integration of ultrasound imaging performed by a clinician at the patient bedside. So you can see in the definition, it's distinctly different from a diagnostic or radiologic study. And the scans, we should be thinking of them before we begin them as being designed to answer focused clinical questions. There are lots of benefits of POCUS, well described in the literature, and they extend to benefits to the patient directly, to the system as a whole, as well as the provider themselves. So they've been shown to reduce the costs and delays associated with obtaining advanced imaging. Been shown to decrease radiation exposure as well as time to diagnosis. POCUS has been shown to limit the risk of procedural complications, and it can really prove quite valuable in resource-limited settings. It's also been shown to increase both patient and provider satisfaction. So POCUS has been around for a number of years, and of course, early adopters of it were emergency physicians, as well as intensivists in the ICU. But in recent years, it's becoming more and more a tool in primary care settings and for generalists. A couple of surveys about 4 years ago published in the CFP, one survey targeting family medicine residents, and another one was targeted at program directors. And they both showed similar conclusions and similar numbers. So over 80% of respondents, both residents and program directors alike, wanted or felt that POCUS training should be part of family medicine residency programs. But about 1 in 5 of those same respondents reported actually having a formal POCUS training program as part of their residency programs. The barriers cited, and these are the barriers that come up again and again in the literature in various contexts, tend to be the lack of funding, lack of equipment, lack of instructors, and lack of time. And that all makes sense. I think what organization wouldn't want more money, more gear, more trained people, and more time at their disposal, right? And so what we set out to do in Winchester was establish a POCUS training program that could address and overcome, at least to some degree, all of those barriers. And so we went with in terms of a POCUS Pro, we went with the Butterfly IQ+, which, as you can see, is a handheld device which can plug into a smartphone or an iPad or a tablet or what have you. And so as a result, it's very portable. And so our journey here in Winchester began with our group winning a prime grant from the DFM. And I better get this acronym right, because I think the director of the prime committee is online here, Dr. Archibald. So prime is the Program for Research and Innovation in Primary Care and Medical Education. I think I've got that right. And so with that grant, we were able to purchase 3 of these handheld units, which included membership. We also purchased a membership or a subscription to the cloud-based image archiving software, which has quite a robust education platform and quality assurance platform, which I'm going to show you a little bit about here shortly. So in terms of our curriculum design, it was longitudinal by nature. It was a little bit front-loaded in terms of starting with some self-study, which looked like some readings from point-of-care ultrasound textbooks, as well as some videos. And we completed this preparation in advance of our in-person half-day workshops, of which we completed four full half-day workshops. And those workshops were focused on reviewing some cases, as well as doing some practice scanning, first on each other, and then on patients in the hospital. And these were really an important part of the overall training program, an important foundation to build in terms of getting those hands-on skills and really appreciating the preparation and ways to optimize the images we were obtaining. In terms of the types of scans that we were learning about, you can see we focused on a variety of organ systems. So this is the table that spells out the types of scans that were targeted for our first year residents. There's another table that describes the scans for second year residents considered to be more advanced type training or advanced scans. So just running through the various organ systems quickly, again, thinking back to those focused clinical questions, these were the types of clinical questions we were trying to answer with each scan. So scanning the abdomen, like a fast scan, is there any free fluid? Scanning the heart, is there a pericardial fusion? Is the cardiac activity grossly normal and organized? In the first trimester obstetric setting, were we able to, can we confirm that there is indeed an intrauterine pregnancy? Looking at the lungs, is there a pleural effusion or a pneumothorax? In terms of vasculature, looking at the abdominal aorta, is there a AAA present? Looking at the kidneys and bladder, is there hydronephrosis or is there urinary retention? Looking at the abdomen again and the biliary system, is there evidence of gallstones or evidence of cholecystitis? And from a procedural point of view, we've been trained to use it for both thoracentesis and paracentesis. And so that was the first aspect of our program. Really, the meat of our program was the period of independent practice. And so this took place longitudinally, was meant to be integrated into our day-to-day workflow. And so we were using these probes in our routine clinical encounters. So for us in Winchester, our program is actually longitudinal by design itself, not just the ultrasound program, but our residency program here as a whole. And so what that might look like is I might have a probe with me on a Monday in the emergency department. I might have it a few times during the week in my family medicine clinic. And maybe on the weekend, I might have a hospitalist coverage and I might be using it in an inpatient medicine service. And so we challenged our residents to submit a total of 25 determinate scans for each of the indications I mentioned before, and a total of 150 scans per year. And these numbers were based on guidelines or curriculum guideline recommendations from our American counterparts from the AAFP. And coming back to that medical education platform and quality assurance software, here's a little bit about what that sort of looks like. So you can see here, I've got a number of scans on the left side of the screen. This particular study was done for the setting of abdominal pain, and I've completed a worksheet here for the gallbladder. And the worksheet has me answer specific questions. Are there gallstones present or not? Does the gallbladder wall look normal or not? Is there pericholecystic fluid? Is there a sonographic Murphy's sign? And how does the common bile duct look? And I've highlighted here with my arrow during the scan, this particular hyperechoic structure in the lumen of the gallbladder must have caught my eye. And I made a note, said, does that look like a gallbladder polyp? Because to my eye, it did not look like a stone. And that was consistent with the training and preparatory readings I had done. And then I was able to get some feedback in terms of a little bit of knowledge about confirming my suspicion and a little bit of knowledge for my brain hole. And then finally, the quality assurance aspect, comment on whether the images were considered to be adequate or determinate or not, as well as my interpretation of the images. And so this is a tally of the number of scans completed by our 6 residents through the first 6 months of the program. So this is from late December or early January of 2023. And so what the numbers work out to, if I divide 448 by 6, that works out to be about 75 determinate scans for each resident through the first 6 months. which at that point we were exactly on track, if you multiplied it by 2 for the last 6 months, to achieve the target number of 150 scans by the end of the year. The other aspect to our training program was more of a formal or objective evaluation. So in addition to quantifying the number of scans as a whole, we sought to provide some feedback to our residents in terms of how well they were doing at acquiring and interpreting those scans. And so we evaluated our competence serially using this tool, which is called the Ultrasound Competency Assessment Tool. And this is a validated entrustment-based tool. It was meant to be used like on the job and getting feedback from a preceptor with POCUS proficiency. So often that was in the emergency department setting, just because of the current state of POCUS comfort with preceptors. Many of them are working in the emergency department, but not always. We've had UCATs completed in the hospitalist service as well as in the clinic, depending on who our particular preceptors might have been. So the first UCAT was completed immediately after our training workshops and before we began that 6-month independent practice period. And the second UCAT was completed 6 months later. And so we've got here is the proportionate distribution of competency rating. So if I sort of step through each domain, we've got the domain of preparation, the domain of image acquisition, domain of image optimization and clinical integration, UCAT 1 and 2. And the rating scale being competent performance for some of the criteria, most criteria, and all the criteria. And what we can see is from UCAT 1 to UCAT 2, the proportion of responses improves a little bit. So it tends to be that more of the UCAT responses more of the residents were considered to be competent in their performance of all the criteria in the domain of preparation. Similarly, in the domain of acquisition, again, in the domain of image optimization, and the same was true for clinical integration. And for the entrustment aspect, this is a sort of a 5-point Likert type scale ranging from the preceptor essentially having to do the scans for the resident, to having to talk them through a little bit, to prompting them from time to time, needing to be there just in case, and then the preceptor feeling they did not need to be there for the resident at all. Again, from the UCAT 1 to the UCAT 2, what we see is really a shift. A lot of the instances of the preceptor having to prompt the resident really shifted to more of needing to be there just in case. And then this is the same data, just presented a little bit differently, converting the ordinal data to integer data. And then we've got UCAT 1 and UCAT 2. Again, you can see a trend towards improvement in all the domains. The first 4 domains are on a 3-point scale. The last domain is on a 5-point scale. Of course, our sample size was only 6, so this is not analyzed for statistical significance. This is meant to be descriptive statistics to describe how we're doing in our pilot study.
So these data are interesting to us for a lot of different reasons, but I think the one thing that really jumped out at me looking at some of these numbers is that we do look like we're getting an improvement in the residents' competency, even though we're not really providing more didactic training. So you'll recall we started with 4 of those workshops at the beginning of our project, like in July. And then we mostly just followed up with a period of independent practice where we gave the residents probes and we said, go have fun, see what happens. And we'll watch you online with this feedback system where we can sort of text and chat back and forth. And really, it's just been that texting and chatting back and forth with the residents practicing on their own has been probably the big driver of this improvement in those scores on our measures of competency. So that's been really interesting. So that suggests at least that the independent practice and this system of remote feedback really does seem to be effective in getting them to build their skills. What I think has also been interesting has been seeing the wide range of productivity that those residents have produced. So if I put up that table that Sean showed you before, you can see when we look at the total number of scans completed by residents in that far right column, I've got some residents that are super productive. So at 6 months, completing over 150 scans right off the bat. And then I've got some residents that really haven't been very productive at all with only 13 scans at 6 months after their first training. So what does that mean? So I think the easiest and most straightforward interpretation is that some residents might just be better suited to independent practice than others. But I think you could look a little deeper in that, and there are some alternative explanations. One is that residents do tend to pursue their own interests. So, and you can see that if you look at the nitty-gritty of some of these numbers. So one of my more productive residents has completed 35 fast scans, but only 6 biliary scans at 6 months. And then if I look at a resident that's maybe not as productive, I've got someone who's only completed 9 fast scans despite completing 19 biliary scans. So that would suggest at least that residence is finding, biliary scans more useful or more interesting than they are just looking for free fluid. And I think that's something that you can see when you're talking to the residents as well. They find some scans more interesting or more useful than others. And some of those interests that they may be pursuing are not really captured in some of these data. So sometimes or frequently we'll see residents pursue things that we haven't actually taught them yet. So occasionally we'll see scans that show up for 3rd trimester pregnancies, or we'll see scans for musculoskeletal or soft tissue scans that they're doing in the office as they get a patient that presents with, a skin infection and maybe an abscess, or they get a pregnant patient that presents with a, 3rd trimester prenatal visit. So that's interesting too. And some of them have, accumulated quite a few 3rd trimester scans, which is not really captured in the table here because we just haven't got that far in the curriculum that we've been teaching them. And that produces some implications for supervision as well, which I'll talk about in a sec. The other thing that's interesting too is to see that some of these scans have been excluded because either the worksheet was not completed or the scan was not completed. So on the cloud system where we get to monitor these residents remotely, there is a collection of scans that look like they've been started but not actually finished for some reason or another. So a resident will start scanning, but then for one reason or another, they'll abandon the attempt. And sometimes this is because they're missing patient demographics or something like that. And sometimes it's because the scans were clearly just not going well. So they just got blurry pictures of an aorta and they showed me 2 images, but not the full complete set. And the resident just decided not to submit it completely. So knowing that some of that is happening in the background suggests that the residents probably are practicing more than what we're measuring here. So they may be doing scans and just not saving the scan. So their numbers may actually, and I think are quite likely to be higher than the images here. These just refer only to the determinate complete images, not the complete picture of what they're doing and what they're practicing. And I think that's another point that really points to the importance of supervising them. So I really do think the residents need a supervisor with this kind of thing, because if a resident is starting a scan and then not completing it, it's important to talk to those residents and figure out what's going on. What are they struggling with exactly? What made this difficult? And how can we teach them more? How can we help correct them to build their skills? And also, if a resident is pursuing something in their own personal interests, like they're doing 3rd trimester scans and we haven't taught them how to do that yet, are they being safe with that? So are they using this as just practice time to pursue a special interest, which would be a safe approach? Or is this somebody who thinks they are competent to do a 3rd trimester scan, even though their training is not complete, which would not be a safe approach? So someone needs to be following up with this residents no matter what they're doing, because we've got to be able to keep an eye on them. This is not just giving the residents a probe and saying, go practice and then come back. This is giving the residents a probe and saying, go practice, tell me how you're doing, and I'm going to go over some of those scans with you. That's the approach, I think, that improves their learning and improves their skill and also helps us keep patients safe. In terms of how this study is going, I think the most interesting part of this, or the biggest strength that we have, is that we've really tried to direct our approach towards addressing some of the barriers that come up in the literature. Those barriers are the same every time. It's a lack of funding, a lack of equipment, it's a lack of instructors, and it's just not enough time to teach this in the curriculum. With respect to the funding and the equipment, I think handheld devices really are an opportunity here because those handheld devices have increasingly become more and more affordable. You still need funding and you still need equipment to run a program like this. Nothing is free, but a butterfly, the probe that we've used as an example, usually costs around $3,000. And the cheapest cart-based machines that you see in a hospital are usually over $20,000 and probably more than that most of the time. So financially, this makes a lot more sense. We've also been able to practice by scanning patients at the bedside instead of hiring models, because remember, all of those models that you see at weekend ultrasound courses are people that you have to pay, which further inflates the price. Patients are surprisingly game. If you tell them that we're practicing with this machine, we'll show you a picture of your heart, a picture of your lungs. Patients really do want to participate, and it's very easy to get practice in on volunteers. With respect to the instructors, the image archiving, where you save images and then you review them remotely and you provide feedback over the internet or over our QI system, really does help limit the number of instructors you need, because just one instructor with an asynchronous approach is able to supervise a large group of learners. So you don't necessarily have to have an instructor and a learner at the bedside for every single scan. And our approach does look like it's working. In terms of how much time you've got to produce in the curriculum, scanning patients just at routine encounters when they see them in the clinic reduces the overall amount of curriculum time that you've got to devote to this. So there does have to be time where you have a deliberate practice round, and it probably does need to be outside of regular clinic hours at an academic day, just so that you can get the kinds of one-on-one attention that somebody needs when they're first learning how to do this with hands on a probe. But once they have the basics, you can probably just unleash them and let them use this as they go through, in the same way that you would teach somebody how to read a chest x-ray or how to read an ECG, right? Like you first learn that in a classroom in a simulated environment, but then most of your practice time really happens just as you go through residency. And you don't have to devote tons and tons of workshops or lots of academic day to teaching chest x-rays and teaching ECGs. The approach is the same with POCUS. I think there's also an advantage here in that you allow for some spaced repetition in different scenarios and in different clinical settings with different patients. And there's some data that shows that that does improve skill retention. So instead of doing this just at like a 1 day or 1 weekend workshop where they learn everything all at once, you spread this out over a year, over 2 years, and they probably retain those skills a lot better. There are definitely some limitations to what we've done so far. And I think the biggest one is that we have a very small group of residents. So we've only had 6 participants so far, which really limits the amount of statistical analyses you can do. I'd really love to say that, you know, at 0 months, there was a significant difference when I compared them 6 months later. But, you know, I just don't have the statistical power to really be able to do that with 6 residents. So I can only comment on trends. The other limitation too is that the people we had assessing competency, the vast majority were not really blinded to the study hypothesis. So most people knew that we were expecting competency to change at the 6-month mark. And as well, I don't have a comparison group. So there's lots of different ways to teach POCUS. What we've done is one variation. I don't have a second group of residents that's done a weekend crash course that I can also test their competency at 6 months. So I think our approach where we spread learning out over time is probably superior to a weekend crash course, but I can't really say that I have data to support that. That's just my own instinct. In terms of the next steps and what we should be looking at going forward, for us locally, it's probably just get more residents and get more data. So next year we have 7 residents that are entering into this program. So that'll bring us up to 13 and get us some more numbers. So that'll be interesting to see if this trend holds. I think if the trend does hold and things are looking good, in my mind, the next step is to try and take what we've accomplished and move it to a different site. So there are similar efforts going on at different sites. There are some butterfly probes floating around at the Civic campus now. And I would be interested to see if you can still see initial training followed by a period of independent practice and measures of competency improving in the same way at a site that is not Winchester, with residents that are not associated with me, with a lead that is not someone like me, that it's someone different. Does this still work somewhere else? And I think that site should tailor the approach as needed. So I've got my own list of indications for the things that, you know, we thought we could teach here. I don't think another site has to do the same thing. I think it should be geared towards the kind of practice that that site is teaching. It should be geared towards the kind of expertise that is available. And we've done workshops up front with a particular approach, and I don't think you have to do exactly the same thing that we do. I think you can tailor that towards the resources that you have available and the interests of the crew that are at that site. The question really is, does the independent practice work, and do measures of competency continue to improve at the 6-month point? And I think the big thing that pushes this along is probably selecting a POCUS lead. So we've shown that one person or one instructor should be able to supervise a group of at least 6 residents. So you probably need to select a supervisor to make sure that somebody's looking at these residents and watching what they do when they do practice independently. And then you need to be able to secure funding to actually get probes purchased and to make sure that that POCUS lead is a funded position, that they're getting paid for that kind of work. So these are the references that we meant there. We can put those up if we need to. And a few acknowledgements to the people that helped us with this project. So, of course, to the Prime Committee for awarding us that grant, to Dr. Wu, who helped us design the study and helped us review the manuscript, to Dr. Padro, who similarly reviewed a lot of what we were doing before we implemented it, and then to Dr. Begareth, who is the site director at Winchester, who helped us integrate our POCUS into the existing academic curriculum. And I think that's it. So we can take questions if anybody has them.
Sean and Adam, thank you very much for that presentation and introduction to POCUS. I think this is an excellent example of a technology, a rapidly evolving technology that is having impact and is affecting practice for sure. I imagine there's lots of questions for discussion. I've got some questions, but I'm going to hold off on them and let others have a chance to ask their questions and engage in this conversation. So I saw Ed, your hand is up first, and then Parisa.
Thanks, Adam and Sean. This is great. Very, very exciting. And I like the way this is going. I suppose I've got probably a million questions because it all has to do with curriculum, and curriculum is near and dear to my heart. So I guess the specific question I have is recognizing your acknowledgements and seeing where this is going and how it's locally flavored. Are you getting the sense now, because there's been an effort across the department to try and integrate this in every single teaching unit and in the community as well? Do you get a sense now that this, because you had mentioned the civic specifically, that there is the ability to roll this out, and with your meetings with Dr. Wooltorton and getting faculty development on board, can you see, I guess, a way forward, or do you think that there's still more steps within faculty development? Because that's one of my concerns, is getting cloning the Adams of the world and the Jasons of the world. But I know there's also Sufyan and there's other people who are interested in this. And from my perspective, I want all the totality of residents to have a not a perfect experience, but a pretty good experience by trained facilitators. And that requires everybody to get involved as opposed to working in silos. And do you see that starting to happen, or do you feel that there's something else that needs to happen? I'm not sure that Eric's necessarily on this, but I'm happy to pass on your words of wisdom to make sure that we have a great curriculum across the board for everybody.
Yeah, I think there probably is a path forward. There's certainly been a lot more buzz about it over the last couple of years. And I think the program in Winchester has also made some noise among the residents, even not at our site. I think they've been chatting sort of among themselves. So there's certainly more pressure from the residents that we produce something that is, provides them with some POCUS training. I think the barriers remain the same. So we still need to talk about equipment, we still need to talk about expertise, and we still need to talk about time in the curriculum. And we've produced a model that tries to minimize that, but nothing has been eliminated. I do think that there is a path forward, which probably involves first electing people to actually be a site representative or a site lead that would take this on. because again, the residents need to have a supervisor. You can't just put probes in their hand and just let them run. Like someone's got to be teaching them and watching what they do. I think in my mind, the approach is probably best done with sort of a leapfrog approach and learn as you go. So if things work with a particular move at Winchester, and that seems to be going well, then it might be reasonable to take our approach at another site. So you elect a lead at that site, or maybe 2 sites or 3 sites or whatever. You provide them with the equipment, and then you sort of see what that site comes up with. And then, take the errors that they make, take the successes that they have, learn from it, and then take that and then move further forward. Implementing, this broadly across family medicine is something that's going to take time, and certainly will take money and effort. So I think you want to do this intelligently so that you're investing your resources in a particular way. But I do see probably the first step in a path forward is getting someone who can be a POCUS supervisor and finding those people and then sort of putting them in a good position to supervise and work with the residents.
Thanks.
Thank you. This was excellent work. I'm so excited that POCUS is becoming so easily available and cost affordable. So I have 2 questions. Number one, actually a comment. I agree with Ed that we need a critical mass of faculty supervisors. Now, we could do 2 ways. You could do site approach, but we could also do organ approach, right? Or specialty approach. So we do have a critical mass of, for example, women's health experts in the faculty. So if we could have a faculty development for those of us who do women's health, for the first trimester, location of the fetus, but also IUD placement, because more and more women are actually requesting ultrasound guided insertion. That would be very good, because we could definitely pass that knowledge to the residents and watch them and give them the skills and evaluate them, because you also need inter-rater reliability on your evaluations, right? We want to make sure different eyes look at them. So that's more like a comment for faculty development opportunities. We would be very interested in doing that, and I know that Sony Singh really wants to get family docs trained in OB POCUS. So maybe an opportunity for collaboration. On the question, when many years ago I did POCUS training, we actually had to get our certificate and then competence maintenance. So there would be a number of POCUS I would have to do per year. I did that through CHIO to maintain my competence. Is that still the case?
It depends on who you ask, actually. So the most common certifying agency in Canada right now is CPOCUS, which is the Canadian Point of Care of Ultrasound Society. And their guidelines generally suggest that you need a certain number of proctored scans, you need to complete a certifying examination, and then you need to maintain those skills with a certain number of continued work and other examinations.
But that's for diagnostic, right? Because I loved your definition, right? We're not diagnostic. We're putting clinical picture, right? We just want to make sure the IUD is in the right place. So for that, do we need a certificate,
So again, I think it depends on who you ask and what the goals of your scan will be. So an example of that would be in the emergency department, where POCUS has been around for a while. The schedule of benefits generally says that you need to have a certification or some kind of equivalent certification if you're going to bill for this. If you were to use this in your office for a limited examination, there is not any particular governing body or any particular ultrasound police that's going to come in and say you can't use this because you have not done enough scans. So that is controversial because most people probably should have some kind of certification or some kind of record of training to ensure that they are competent. But there's not necessarily any real enforcement going along with that. Does that make sense?
That's great. Thank you. Yeah. Bottom line, get your certificate, maintain your skills. I think that would
Correct.
be most prudent as supervisor, as faculty supervisor, right? It's important to have that. Thanks.
I think so. Yeah. I think of this much like, every other sort of diagnostic test. If you're reading chest x-rays, you probably have to have enough regular use of reading chest x-rays to maintain competency with it. But there's not necessarily somebody walking around checking to see if you've read chest x-rays or not, right? So if you are new to this and there is a certification program, that may be something that's very worthwhile to pursue just to keep everybody on their toes. But not everybody is going to do that. It's sort of how it goes right now.
Great, thank you, Adam. Jason.
Hi guys, great job. I don't want to steal. I could talk about POCUS for another hour. I'm not going to steal away from your awesome presentation. I just wanted to put a couple comments out there. One of which is this idea, and I hear you. I hear everybody about wanting to do these specific, indications and have special interests, and maybe not, going through maybe what we would call a fundamental kind of curriculum of learning how to do the FAST and whatnot, but if we go back to what we're trying to do here, I think it's try to improve our family medicine program and make the generalist more of a generalist. And I think that if we think about who we are actually teaching, we're trying to teach family physicians that can work in any environment, which requires that they do all types of scans, not just what they like. And some people will want to take it on and some people won't. And why I bring that up is that I feel that if we are not we do not follow a recipe on how we go about teaching this, and we kind of learn all these nooks and crannies of using POCUS, we're not going to build the capacity that we need as faculty that can be kind of teachers everywhere and to a lot of indications. And I think that, and two, we're not preparing our future family physicians for working in any type of setting, whether it's rural or urban. And so I hear everybody, and I think we're trying to figure that out is how do we tailor this to the needs of the learner, but how do we give them a fundamental kind of basic skill of some of the kind of core ultrasound indications. And we don't, I don't have the answer to that. I think that we're kind of trying to duplicate what all the great work that Adam's done with a little bit of small little tweaks. But I just want to bring that back because I feel that we may lose a lot of impact and a lot of coordination and a lot of efficacy when we're implementing this in family medicine if we kind of go all into our little kind of camps. And I just wanted to put that out there because I think that there is going to be times where you have to learn how to do things that maybe you wouldn't be doing all the time, but are going to make you a better kind of preceptor, which is deeply what we need. We need to build capacity from a preceptor perspective. I hope that makes sense and wasn't too wordy. Sorry, guys.
Yeah, I think that does make sense. I think one of the worries, particularly with a new skill or a new program, is that you try to do too much too fast, right? Like we teach all of the different indications and we focus on breadth without focusing on enough depth to build expertise within a particular program. And that's something that is challenging. And I don't actually know the best approach to that. One of the things that makes implementing POCUS in family medicine particularly difficult is that there is no real consensus about exactly what a family doctor should be able to do with a point of care ultrasound. And some indications are likely to be very useful to some family doctors and not useful at all to other family doctors. So, an example might be teaching someone how to find a pneumothorax, which would be very useful if you were the kind of family doctor that works in the emergency department. But if you're likely to do an office practice or focus on obstetrics or something like that, you may have a completely different set of interests with respect to what you might learn in POCUS.
And the last comment, sorry to just speak up here, is that I think that's what we need to start to align. Like, if I told everybody here that when they were doing their urgent care clinic that they could, not need to have a chest x-ray for a suspected pneumonia, and I know there's different practice variations, and you could have the answer of whether this is a pneumonia, a viral pneumonia, or a bacterial pneumonia in clinic with you, would that make you feel better as a clinician diagnosing pneumonia? Or if you suspected a DVT and you could rule that out in real time and save a visit to thrombosis or to the emergency department, would that be worth our time? And I think we need to start speaking about it in those terms, because those two indications, POCUS actually outperforms what we standardly do as a standard of care. And I think we need to be thinking about those to maybe start to congeal people's views about POCUS and the usability and the applicability of POCUS.
Thanks, Jason. Just, I hope everybody's taking a look at the chat. Dr. Liddy had to leave, but she just wanted to stress the point that we are beginning to fund both training and equipment for this across the department. Seeing this as something that is an adaptable technology for sure. A word that we are using quite a bit now is adaptivity, right? Being readily capable to adapt, a trait that we want all family physicians to have for sure. And I think, some of the data that you presented, Sean and Adam, just, with the 6 residents that participated and how they are using this as a tool, right, for a specific need. They have a certain interest and they're using it. And I would foresee that this would be how, as a tool for a family doc, in their office, for certain needs that they have. And I just had a question around time. Just some of your examples here, like, identifying whether there's abdominal fluid. I would think that would be something that you can say yes or no quite quickly. But the example, like with the cysts on the gallbladder, and there are a lot of images there, how much time would that take to identify, like, whether there's like a cyst or not, like once you're proficient at it? I'm just thinking in the office practice, how feasible is that to do? Or is that something that you wouldn't do in a typical clinic visit?
I think it depends. It depends on how much you practice and how proficient you become. Depends on the patient in front of you and their body habitus and their particular anatomy. Some of the scans can be a couple of minutes. Some you may struggle for 5, 6, 7, 8, and then those may be some of the scans you abandon despite really wanting that answer. If you're not able because of your own skill or the patient in front of you acquire that image, then so be it. You don't let the result of that scan modify your your differential diagnosis or your pretest probability. But it's on that order. It can be as short as a couple minutes, and I probably don't push many beyond 6, 7, 8 minutes. So I think it's in that range.
Gotcha. Thank you. Risa.
Sean and Adam, are you both mostly in Emerge?
I mean, I'm a family medicine resident, so
okay, but your training is happening in Emerge, like all these the residents, the data collection is coming from Emerge, correct?
No, so again, like I use that probe, like where it's portable. I just plug it into my smartphone, right, and I carry it to a family medicine clinic when I'm on hospitalist service. Our first year residents do some OB clinics, so they'll take it with them in that setting. So wherever we practice, we've had residents take a probe up north even, so on elective. So there's lots of options to take it anywhere.
The only reason why I bring it up, it's important because as excited as I am, I'm also wanting us to proceed with caution, because one resident at Bruyere has got his probe and constantly scanning everyone all day. And I find, as an old-fashioned family doc, I just don't want more time spent on a screen with a patient than it is absolutely indicated and necessary. So while, and that's why I ask Ed in terms of whether or not this is a competency that we need to show, whereas we do know communication skill is a competency we need our residents to know of upon graduation. So I'm just always nervous when more technology comes to interfere with our core business of patient-centered and relationship-centered delivery of care. So perhaps we need to find the sweet spot on that. And maybe that's why it would be good to have dedicated academic days, you know, where they get the skills, or I don't know, virtual reality programs where they practice, etc. And then sure, they have 2 or 3 per day that they do, but not necessarily on every patient, because it just slows them down and it takes them away from reviewing the patient's medications, or when was the renal function done on it, you know, on blood pressure meds, etc.
Yeah, absolutely. There's a problem, I think, with any kind of new technology, and that it's a shiny object and it distracts people from things that actually matter. So I think there is an education piece and again, a supervision piece that has to happen. So one of the things that has really changed the landscape over the past couple of years with the declining price of these handheld ultrasound probes is that the price of the probe is now very much in the reach of an individual physician. So if you have $3,000 that you're willing to spend on medical equipment, you could buy yourself a probe right now. And it's very possible that you're going to have residents that show up having purchased their own probe. And the thing that always makes me a little nervous about that situation is, what is that resident doing? What kind of training do they have, and who's supervising them? So beyond simply, you know, that resident maybe, you know, spending time practicing something that may not be worthwhile or may not add to patient care, there's also the possibility that that resident is performing scans and making decisions with those scans despite not having appropriate training. So again, I think, you know, the residents need some kind of supervisor, and the availability of a lot of handheld devices coming around now probably behooves us to build some kind of structure for what we do with POCUS, even if there is no particular list that is built into current, you know, educational standards in family medicine. This is the kind of thing that's coming, you know, no matter what we do. So I think we should probably try and be ready for it, or as ready for it as we can.
Victoria.
Hi, I guess I just wanted to add that as a fairly novice POCUS user, like having done some training in my residency and then become certified in the last year, I actually feel that it's a piece of technology that brings me closer to the patient. So I don't actually, I would contend that it doesn't become an obstruction or a barrier to that patient interaction, because often you're providing an extra service to the patient that they didn't even know you had the capacity to do. That's going to kind of reduce barriers to their care. It's going to maybe prevent them from having to go for urgent imaging or urgent, you know, emerge visits or things like that. So I actually think in the times that I've been using it recently, it's been seen really positively by patients. And I feel like even for myself, it has connected me more to the patient, because I feel like I've done a service that's kind of expediting their path to care. So I think we can be reassured that it's not, yes, it is a screen, and yes, your eyeballs are looking at something else, but your hands are on the probe, but you're also touching the patient. So there is that contact piece physically. And there's also the, again, kind of a sort of expedited path to care that you provided for them directly, which I think is really satisfying for yourself and for the patient. So I just wanted to bring that kind of as a positive that I've been seeing already.
Yeah, thank you for that comment. We do have data that shows that it improves patient satisfaction. So we know the patients do like it when you're doing it. So I think if you do have someone who is appropriately trained and they're using it well, I do think it's a worthwhile thing to do most of the time.
Please.
Hi, thank you very much for great presentation, and thank you to everybody who's working to move to bring POCUS into family medicine. And I just want to, for one thing, I want to echo Victoria's comment. I come to this from a different perspective, having had POCUS as part of my residency training a long time ago in Europe, where I went after finishing med school at McGill, and having that ability to do exactly what Victoria was describing, do things in the office, avoid emergency referrals of different sorts and all that. And when I came to Canada, I was very happy to find a number of things that I had missed when I came back after 10 years. But the one thing that I really missed was like, where's my ultrasound machine? I was job sharing with a colleague in Europe, and we had our own clunky, low resolution, 30,000 euro device in our office, right? But we were able to do things with it. And I really missed that. And there was this vacuum when I came back. And of course, that wasn't sort of my main focus. So I just kind of put that aside. So I'm very happy to that we now have people like all of you here who are working actively with POCUS, like Jason and Adam and so on. So really happy that you guys are doing that. And I might consider refreshing my skills and getting recertified, I think, because I'm just excited, especially now with the portable devices and how accessible they've become. So I see this as a real asset. And yes, there needs to be a framework. Yes, there needs to be supervision. We had to do 400 abdominal ultrasounds under supervision to be certified. So it is a lot of work, and the more you practice, the better you get. So thank you so much, everybody.
Well, this has been a very engaged conversation. Great topic. Sean, Adam, thank you so much for wonderful presentation, great discussion, and thank you all for joining today. I would like to mention that this is an accredited program, so please do complete evaluations. I think they'll probably be posted here in the chat. That's important for us. And as I mentioned, we're taking a break over the summer, and we'll begin again the new academic year come September. And already we've got a lot of great presentations lined up. So thank you all very much for your time. And I can see now we're just about 9 o'clock. Any last closing words from anyone?
Since I've got an audience, I'll just take one quick minute to embarrass Dr. Jones-Delcorde here. So if you ask him, I know he'll minimize it, but he put forth a huge amount of effort getting this program stood up and off the ground. And as a learner, as a resident, I benefited two ways. One, developing my POCUS skills, most importantly, but also from the research and medical education side of things, I was able to develop that way. So I wanted to thank him in front of everybody for that. And this has been the highlight of my residency training.
Thank you.
Well, on that note, thank you and congratulations. So we'll see you all in September.